Which brings me to our research at Children's Hospital, which is a tertiary quaternary care center, which basically means we see some of the most complex children in the province. We ran the group out of the neuropsychiatry clinic at the Children's Hospital, and we recently completed data collection on 15 groups, which took many, many years. I believe it was 7 years to complete. And we used the modified CBT group protocol developed by Dr. Reven and her colleagues called Facing Your Fears that Dr. Weiss mentioned briefly in his talk. And it was for children with autism between the ages of 8 and 12 and included a parent, so the children had to attend with a parent. And we had up to 5 families participating in each group. There were large group components, parent-child pair work, and breakout groups where the parents and children separated and went into different rooms. And speaking to the support of parents, that was definitely something that we heard a lot from parents, how helpful it was to be with other parents tackling some of those same issues. The group was 14 weeks plus a booster session, which was 2 times as long as similar treatments in the community for typically developing youth. We had 50 participants consented to participate in our research, which I'm very proud of and grateful for. The average age was 11, and IQ was also in the average range and had a very wide range. Participants were mostly boys, parents were mostly moms, and our ethnicity of the groups varied. We had a very complex population of children participate in the group, which included, but was certainly not limited to, things like mood disorders, learning disabilities, attention issues, mild intellectual disability, and behavioral disorders, etc. Research screening included multiple parent-child measures, which most importantly included measures of anxiety, which included an anxiety interview with parents and parent-child questionnaires. At minimum, we recommend a measure of anxiety symptomatology be delivered at pre and post in order to support the evaluation of outcomes for this group. Our inclusion criteria included children with autism, so they needed to have a diagnosis of autism to participate in this particular group, be between the ages of 8 and 12, have clinically significant anxiety as determined by a clinician, be verbal, and preferably have a reading level about a grade 3 level. Exclusion criteria for our particular group was IQ below 70, primary OCD or depression. They could have OCD or depression, but it couldn't be their main concern at the time, and significant behavioral difficulties that would make it difficult for them to participate in the group treatment. Groups were generally mixed of boys and girls, and similarly aged children were grouped together, with younger children grouped in one group and older children typically making up a second group. We very carefully considered the amount of support required for each child to participate in the group, and so we considered the number and severity of difficulties represented for each child in terms of their anxiety level, behavioral issues, and even other coexisting issues that would require some support. And it certainly is possible to have a manualized group treatment for children with autism be individualized. I think one of the keys to our success is that we actually really took a lot of time before group, up to an hour and a half prior to each group, to really plan and make individual plans to support each child in the group, make sure that they were set up for success in terms of behavior plans for them and individual plans to kind of tailor the group treatment approach for them, and plan for the exposure practices as well, so that we went in with a range of different plans that could be appropriate based on how the child was doing that day. And interests and personality were also considered when matching to group. We ran the group with 3 to 4 clinicians per group of 5 children, and this was especially important when we considered the split off part of the group where the parents go in one room and the children stay in the other room. We typically had 2 clinicians with the kids and 1 clinician with the parents. And while there are some clinicians that are skilled in all of these areas, including having high level of expertise in CBT, ASD, behavior management, and mental health clinician, it's certainly not necessary for all clinicians in the group to have experience in all all of these areas, and it certainly worked very well to have clinicians be skilled in one of these areas and work together to represent each group. And these are the types of things that we'd be looking for to build groups of clinicians. Speaking from personal experience, I found that it was a fantastic learning experience as a graduate student with appropriate mentorship provided. So there was a wide variety of anxiety disorders represented in the sample, most commonly specific phobia, social phobia, and generalized anxiety disorder. And we had a large number of research questions we were looking at, 2 of which were, is this treatment acceptable for families, and is this treatment effective in reducing anxiety? Speaking to the acceptability, we had very high attendance ratings, very high attendance at the booster sessions, low attrition, and high parent satisfaction ratings, which were very encouraging. When asked what was most helpful about attending the group, parents gave really wonderful feedback. They said being able to openly and freely discuss fears without judgment, things like not being alone, things like realizing what a real fear is and what is just a false alarm reaction were very helpful and very common responses, which was very encouraging. Early analyses found a statistically significant difference in the number of anxiety disorders from pre to post group. On average, the number of anxiety disorder diagnoses reduced by 1 after participating in the group, and overall severity ratings of anxiety were also significantly lower after participating in the group.